Hi, very good morning. I'm Dr. Janak Patel, MD General Physician. Today we'll be discussing on very odd topic, that is Takayusu disease. It is the involvement of the artery. It is a rare disorder, not very common, but you might see once in a while such patient. You will have to differentiate from other disorders like atherosclerosis, arch of aorta aneurysms, coarctation of aorta, etc. becomes a differential diagnosis. So you must be aware of such disease called Takayusu. The different varieties we'll be talking all, maybe asked as a 5-mark short notes, but still I felt that you should be aware of such disease. So Takayusu disease is an idiopathic inflammatory disease involving large arteries, that is arch of aorta, branches, ascending, descending aorta, etc. It is common in young individuals and it is resulting from an occlusive or ectatic changes, mainly in aorta. That's why it is also called as aortic arch syndrome. As well as it can involve pulmonary artery and its branches. So it is an inflammatory stenotic disease of medium to large size artery characterized by involvement of aorta and its branches, also known as aortic arch syndrome, or also sometimes the word utilized is pulseless disease because of occlusion of those large arteries. The pulse is absent and usually upper limb is more involved as compared to lower limb. Angiographic classification wise, it is divided into type 1, type 2A, 2B, 3, 4, 5. I'll just show you in a photograph wise. According to American College of Rheumatology, it is classified into, and different criteria are utilized: age, claudication, brachial artery pulse, blood pressure difference more than 10 millimeter of mercury, presence of bruit over subclavian artery or aorta, and arteriogram. Depending upon that, it is being criteria are being utilized for classification of Takayusu disease. So you utilize all these criteria including age of onset, claudication, brachial artery pulse, one unilateral or bilateral, blood pressure difference between two extremities, mainly upper extremities, bruit, and arteriogram. So those are the criteria which are being utilized. And this is the classification depending upon which portion of the vascular system is involved. If there is involvement of pure aortic arch only, then it is called type 1. If there is involvement of ascending aorta with arch and its branches, then we call 2A. And if it is ascending aorta, arch of aorta, its branches plus thoracic and descending aorta, then it is called 2B. So this is pure ascending aorta with its branches, aortic arch and branches, while this is ascending aorta, arch, descending and thoracic aorta and its branches. 3 is purely where ascending and arch is not commonly involved, while it is involvement of thoracic descending aorta, abdominal aorta, and involvement of renal arteries. Type 4 is mainly abdominal aorta. There is no involvement of thoracic aorta, so it is abdominal plus renal. And type 5 is combination of ascending aorta, arch of aorta, thoracic aorta, abdominal aorta and branches. So type 5 is entire aorta involvement and branches. Type 1 is only branches from arch of aorta, while type 2A ascending aorta, arch of aorta and branches, while type 2B is ascending arch, thoracic and descending aorta. And if it is only thoracic and descending aorta, thoracic portion and abdominal aorta. So type 3 is combination of thoracic and abdominal. Type 2B is ascending thoracic and descending aorta. And if it is pure abdominal, then it is type 4. And type 5 is type 2B plus type 4 involvement. So this permutation combination, that is the classification by angiographic involvement. So American College of Rheumatology gives a diagnostic criteria, that is age less than 40, claudication in upper extremity mainly or maybe lower extremity, decrease in brachial arterial pulse, systolic pressure difference more than 10 mm of mercury between the two arms, bruit over subclavian artery or aorta, and aortographic abnormality more than 3 criteria suggest Takayusu disease, more than 95%, 90% sensitivity, and specificity is almost close to 98%. They also include aortographic narrowing or occlusion of entire abdominal aorta and its primary branches or large arteries of both upper limb and lower limb, also included in those criteria. There is another criteria by Ishikawa, obligatory and major. Obligatory age less than 40, and at the time of diagnosis or at the onset of characteristic symptoms and signs of at least 1 month duration. Left mid subclavian artery lesion, right mid subclavian artery lesion. Most severe obstruction occurs in mid portion 1 centimeter proximal to its vertebral artery, to its vertebral, left vertebral to 3 centimeter distal. So if this criteria is fulfilled, it is taken as Takayus. As far as minor criteria is concerned, high ESR, carotid artery tenderness, maybe unilateral or bilateral on palpation, hypertension 140/90, and in popliteal 160/90 at the age of 40 years, less than 40 years. Annulo-aortic ectasia, bi-auscultation, Doppler or echo or angiographic evidence, and there may be involvement of even a pulmonary artery. Left mid common carotid artery lesion, distal brachiocephalic artery lesion, descending thoracic aorta lesion, and abdominal aorta lesion can be the finding on aortography. Obligatory criteria plus 2 major criteria or 1 major and 2 minor or 4 minor, high probability of Takayusu disease. Our Indian Dr. Sharma modified criteria. Major criteria he published in 1995. Left mid subclavian artery involvement, right mid subclavian artery involvement, and symptoms: limb claudication, pulselessness or blood pressure difference between the two extremity more than 10 millimeter, exercise induced ischemia, neck pain, fever, amaurosis fugax, that is blindness, syncope, dyspnea, palpitation and blood vision, more than 1 month duration. And in minor criteria, high ESR, Carotidynia means painful carotid artery on palpation, hypertension in upper extremity 140 by 90 and in lower 160 by 90, aortic regurgitation, annulo-aortic ectasia, pulmonary artery lesion, left mid common carotid artery, distal innominate artery lesion, descending thoracic aorta lesion, abdominal aortic lesion, coronary artery lesion, etc. When you get two major or one major and two minor or four minor, indicates high probability of Takayusu disease. This was by Dr. Sharma, modified criteria. Again same by another group. Criteria proposed, 3 major criteria, 10 minor criteria, all those what we have mentioned before, little modification here and there. So I'll skip over this particular. Now there are different words which are being utilized for this. Takayusu arteritis, aorta arteritis, pulseless disease, young female arteritis, occlusive thromboaortopathy, aortic arch syndrome, reverse coarctation, Martorell syndromes, Dhanraj disease, etc. Out of which the most common utilized is Takayusu, aortic arch syndrome, reverse coarctation. These three are common. Another is pulseless disease, or sometimes they also used word aortoarteritis. So these are all the different terms which are being utilized. 4 types of luminal changes: irregular lumen, ectasia, obstructive lesion, what we call stenotic lesions, which is a hallmark of the disease, and sometimes you come across aneurysm, which can be secular or fusiform. We already mentioned type 1 is aortic arch and its branches, type 2A ascending aorta arch and its branches, type 2B is ascending aorta, arch of aorta plus thoracic aorta, descending aorta and its branches. Type 3 is thoracic aorta, descending aorta, abdominal aorta and involvement of renal artery and branches. Type 4 is pure abdominal aorta, renal artery or both. And type 5 is entire aorta and its branches. This is type 1, where you can see that there is involvement of arch of aorta and its branches. This is 2A, arch, ascending and its branches. 2B is arch, ascending, thoracic aorta and descending, where you can see that abdominal aorta is not involved. So this will be the portion which will be involved. And in type 3, you can see thoracic and abdominal aorta involvement with involvement of renal artery. Type 4 is mainly abdominal aorta and renal artery, while type 5 is entire aorta, that is ascending, arch, thoracic, descending and abdominal aorta with renal artery and branches. As far as etiology is concerned, one of the etiology which is being proven is genetic etiology. In India, it is HLA-B5 and HLA-B21. In Japan, HLA-DR2 most common. In USA, HLA-DR4. These are different genetic marker. autoimmune, it is immune reaction against elastin. There will be circulating gamma globulin which are being well established like alpha 1 and globulins, IgG, IgA, IgM. It is also labeled as anti-aorta antibody, anti-endothelial cell antibody. There will be raised ESR, leukocytosis, arthralgia, and you will have a high titer of anti-aorta antibodies. That is why it is also labeled as autoimmune aortoarteritis. Some patients also were having raised ASO titer. Female are more prone as compared to male. So female predilection is there. Tuberculosis and Takayusu disease, there is a little correlation between these two. So there was also hypersensitivity to Mycobacterium tubercle. So it was also called as tubercular aortitis. There are also granulomas which are seen in a histopathology. So it was also correlating in tuberculosis. There is exactly no evidence for that tuberculosis is responsible for the etiology, but it has been found little correlation with involvement by tuberculosis. Viral etiology, there is always a question mark. Race, we have already told you, it is common in Asian, Indian, Japanese, etc. There is higher incidence. In India, it is more involvement of abdominal aorta, very common. As far as sex is concerned, more common in female. Ratio is almost 1.6 is to 1. Nearly we can say 2 is to 1. Age less than 40 years. Among pathophysiology, it is a panarteritis. There is a mononuclear infiltration, occasionally giant cells. There is intimal proliferation, fibrosis, scarring, and vascularization of media layer. There is a degeneration of elastic lamina. There is a narrowing of the lumen with or without formation of a thrombus. So exact pathophysiology, they say there is some antigen which stimulates the aortic tissue, and there is an expression of shock protein 65 which will produce a chain of reaction. There will be appearance of a natural killer cell we call NK cell which will release pro-inflammatory cytokines. There will be matrix activation, matrix metalloproteinase activation, inflammatory response, and then you will have a destruction. And this particular will involve, we have already shown you 5 different classification. It can be localized, it can be diffuse, it can involve arch of aorta, ascending aorta, any part, but mainly the major blood vessels we call large size artery and medium size artery. A small size artery are never involved, and there are always skip lesions, skip areas in between. So this is a characteristic of what we call as a Takayusu. Descending thoracic aorta is maximally affected area of a affected area. So descending thoracic aorta is maximally affected, and it is distal involvement is more than proximal. So you can have obstacle lesion or you can have aneurysmal formation. You can see the involvement of different blood vessels in different series. This is one of the series which shows that you can see that left subclavian is more commonly involved as compared to right subclavian. Carotid artery are also involved. You can see that among abdominal, superior mesenteric artery and renal artery are more commonly involved. Even you can get involvement of the coronary artery. You can have involvement. Bilateral renal artery stenosis is more common. So these are the different papers which can tell you. You can see the diffuse involvement is more, almost in 62.5%, and there is a thoracoabdominal involvement. While you can see that there is a localized involvement in 37.5, and that is mainly abdominal in adult, and in children thoracic and abdominal. So these are different types of involvements. You can see there is another series where they show that subclavian involvement was almost in 93%. Highest involvement is the subclavian involvement. You can see the second common involvement is a common carotid artery. Then abdominal aorta, renal, etc. These are the common. So you can see that subclavian, left subclavian involvement is almost in 40%. And renal artery involvement is almost in 63%. So these are the different series which shows you different artery involvement. And we have already shown you it is irregular variety or ectasia, or obstructive variety we call stenosis, or you get destruction of the wall and formation of aneurysm, which can be secular or fusiform aneurysm. So as far as clinical picture is concerned, will depend upon the type of presentation. Subclavian is the most common presentation, involvement almost in 93%, where person will present with claudication in upper limb, Raynaud's phenomena. When there is an involvement of the common carotid artery, usually visual changes, syncopal episode, TIA, and occasionally strokes. When abdominal aorta, person can present as an abdominal pain, nausea, vomiting. Kidney involvement, hypertension, and renal failure. Arch of aorta involvement, person can present as an aortic regurgitation and congestive heart failure. Vertebral artery, visual changes, dizziness. So these are the different arteries involved. When iliacs are involved, person can present as leg claudication or claudication in lower limb. And when coronary artery are involved, person can present as an anginal chest pain right up to myocardial infarction, and pulmonary artery atypical chest pain with dyspnea. So disease will depend upon, so clinical feature will depend upon basically involvement and how fast it evolves. Early pre-pulseless stages, where you can have a non-specific symptoms like fever, weight loss, fatigue, headache, arthralgia, splenomegaly, lymphadenopathy, etc., where it will be extremely difficult to pinpoint involvement of the pulse or involvement of arteries, because the pulse is present. But once a person goes into a pulseless stage, where person starts complaining of ischemic pains, so on the side of involvement, there will be decreased pulse or no pulse, bruit, presentation as heart failure, abnormal fundus, and hypertension will be also recorded because of involvement of one side and other artery is not involved. In an early pulseless, fever, weight loss, headache, malaise, night sweats, arthralgia, splenomegaly, lymphadenopathy disappears partially or completely within 3 months, and 50% there is no history of acute phase. In a late stage, now there is an occlusion of arch of aorta branches. There is almost diminished or absent pulse. Bruit is audible. Hypertension is almost seen in 33 to 83%. Renal artery stenosis is almost as high as 75%. And presentation of congestive heart failure is common as much as in 30%. We already shown you 5 different varieties of presentation. Type 1, arch of aorta with branches. Type 2A, ascending aorta, arch and branches. Type 2B, ascending aorta, arch, thoracic and descending aorta and branches. Type 3 is thoracic, descending and abdominal aorta and branches with renal artery involvement. Type 4 is purely abdominal aorta and branches with involvement of renal artery, while type 5 is entire aorta, that is ascending, arch, descending, thoracic, abdominal aorta, renal artery, etc. Complete involvement of aorta. So you will have a constitutional symptoms more common in an early stage like headache, malaise, arthralgia, fever, weight loss. In a late phase, we already told you involvement of the pulse, diminished pulse or absent pulse, bruit, hypertension, heart failure. Coronary artery involvement is not so common but may occur in 10 to 30%, particularly when there is an involvement of ascending aorta. In coronary artery involvement, there are 3 types which are being described. Stenosis or occlusion of coronary ostia. Second variety we call as a diffuse or focal coronary arteritis. And 3 is coronary artery aneurysm. So these are the 3 types which are being described. And this can end up with acute MI and can be lethal. Hypertension is more common when there is a renal artery involvement, and almost it can occur up to 83% of the patient. Aortic regurgitation is more common when there is a dilatation of ascending aorta and the valve gets separated out or there is a thickening of the valve. Congestive heart failure is because of hypertension or aortic regurgitation or myocarditis. Pulmonary involvement is not so common, but angiographically you can demonstrate almost in 70%. But whenever there is a pulmonary involvement, person can present as hemoptysis, chest pain, pulmonary arterial hypertension, etc. And when there is a carotid artery involvement, you can have strokes, TIA, visual impairment. As far as eye involvement is concerned, you can get amaurosis fugax, hypertensive retinopathy, ischemic retinopathy, etc. Cardiac and vascular features, we have already mentioned, person can present with involvement of carotid artery, involvement of arch of aorta and subclavians. So there will be difference of blood pressure in 2 extremities, upper extremity claudication, tenderness of carotid artery, hypertension, AR, Raynaud's phenomena, pericarditis, congestive heart failure and MI. And even percentage are being mentioned. In neurological features, we already mentioned headache, visual disturbances, stroke, TIA and seizures can be also seen. As far as skin is concerned, erythema nodosum, ulcerated subacute nodular lesions and pyoderma gangrenosum, very rare, less than 1%. Erythema nodosum is seen in 6 to 19% of the group of people. So on physical examination, pulse, blood pressure is most important. You have to take in all the 4 extremities. Ophthalmic examination like fundoscopy is a must to find out hypertensive changes or ischemic changes. Blood pressure difference between the 2 extremity may be more than 10 mm of mercury. Left is more involved as compared to right. So left subclavian is more commonly involved as compared to right side. Hypertension can be very commonly because of renal artery involvement, more common than other. There will be absent or diminished pulse is a clinical hallmark. We already told you carotid dynia, that is tenderness. Bruit will be audible on different vessels. Aortic regurgitation may be seen, and changes in fundoscopy examination. Skin may show you erythema nodosum, ulcerating nodular lesions, etc. We already mentioned this criteria. American College of Rheumatology, age less than 40, claudication in upper extremity, diminished brachial artery pulse or even absent, blood pressure difference between 2 more than 10 millimeter, bruit over subclavian artery or aorta, more common on left side, and aortography abnormality, more than 3 criteria, goes straight forward in favor of Takayusu. As far as investigation is concerned, hematologically mild anemia and leukocytosis, ESR will be elevated, ASO titer may be positive, RA factor, ANA factor may be positive, ANCA may be positive. Chest X-ray will show you aortic widening or aortic knob widening. Thoracic aorta may be irregular, decreased pulmonary vascularity. Aortic calcification may be seen, mild cardiomegaly, notching of upper ribs when there is an proximal subclavian block. Lower ribs notching will be seen if there is an abdominal aortic stenosis. X-ray abdomen may show you abdominal aortic calcification. Echocardiography can demonstrate myocardial involvement because of carotid artery involvement like hypokinesia. Fundus examination will be very helpful. Most important test is arteriogram or we call angiogram for carotid artery. CBC, CRP is not of much use. ECG will show you hypertrophy and ischemic changes. ESR and CRP suggest inflammatory markers. MRI will be important. Ultrasound with Doppler of 4 vessel studies, arch of aorta, 4 vessel studies, even ascending aorta, thoracic, abdominal aorta will show you involvement with skip lesions. We already mentioned regarding X-ray chest. Among non-invasive technique, ultrasound duplex scanning is very useful. 2D echo is also useful to find out LV dysfunction and valvular AR involvement, aortic regurgitation. Colored Doppler ultrasound is very important. CT angio is mainly to rule out involvement of aorta, carotid artery, coronary artery and pulmonary artery involvement. You can combine MR with angiography, MRA angiography. Fluorescent angiography of retinal vessel is very informative. PET scan may be done. So you can have non-invasive techniques like MR angiography, which can give you a lot of ideas of involvement of the different vessels. Ultrasound, particularly colored Dopplex, will be very important. Fluorescent angiography will show you filling defects because of involvement of the different arteries. Intravascular ultrasound will also help you to find out the involvement of the intima, media, etc. These are different involvement. You can see skip lesions. There are skip lesions which you can see. Stenotic lesions will be seen. These are this is stenosis and these are skip lesions. So this is stenosis, this is stenosis. You can see here. So you will be able to see that very clearly. These are some of the markers, potential biomarkers. Differential diagnosis, you will have to differentiate from coarctation, atherosclerosis. These two will come topmost on the list. One another close differential diagnosis, but this will be involvement of the little, medium size and small size artery. You can have other conditions like Behçet's, giant cell arteritis, rheumatoid arthritis, sarcoidosis, Kawasaki, etc., where also you can have involvement of arteries. As far as management is concerned, it will depend upon nature of the disease, disease course, medical management, side effect and compliance, and surgical management. Mainly will depend upon the area of involvement and disease activity. Usually, the treatment what is being given is, the most commonly we utilize is steroid. If person is hypertensive, control of hypertension, decongestant drugs, cytotoxic drugs, and in presence of thrombosis, oral anticoagulants. Immunosuppressive therapy is very useful. Decongestive therapy is also useful and antihypertensive for controlling complications of hypertension. During active disease, prednisolone is very important. Once the person goes into remissions, taper the steroids and maintain the remission. If person does not respond, then only immunosuppression therapy like cyclophosphamide, methotrexate or azathioprine is utilized. So decongestive, antihypertensive, main important. Antiplatelet, antitubercular therapy has been tried. Treatment of renal failure. This is a flow charts which you can go through at your leisure time. If there is a stable disease and if there is an active disease, what you do accordingly. This is guideline mentioned in 2008, how you approach to a person, that is how the person responds and how you select a drug. Surgery mainly is required if there is a severe obstruction, in which you can go for balloon angioplasty, you can utilize stent or stent with graft replacement, etc. can be tried. If there is a short segment involvement, balloon angioplasty, stent, graft replacement is good results. If there is a long segment involvement with extensive periarterial fibrosis, usually bypass is of choice. As far as complication is concerned, stroke, intracranial hemorrhage, seizures, graft stenosis and occlusions, ischemia, organ failure, particularly renal involvement, hypertension complications, valvular heart disease, retinopathy, renovascular hypertension, congestive heart failure, and because of long-term use of corticosteroids, lot of complications like cataract, HPXA suppression, hyperglycemia, hypertension, osteoporosis, fractures, aseptic necrosis, etc. So I end my lecture here. I am very thankful to you for taking out time. I know that your time is valuable and I appreciate spending some of that with me. I hope this may be helpful sometime in your everyday practice. If you come across difference in pulse or low volume pulse or absent pulse in upper extremity and lower extremity, and if there is a difference between the two, do keep it in mind. It can be Takayus, particularly if there is a difference of pulse in two upper extremities, which is more common.